Recording in progress.
Hola, buenos días, buenas tardes, buenas noches.
Hello, good morning, good afternoon, good evening.
Night. We are at the very beginning. I want to say that you can choose in the bottom of the screen a word for the interpretation. You can choose the language that do you prefer. Podemos encontrar en la base de la pantalla un puntito.
At the bottom of your screen, on the toolbar, you can see a globe. There you can click on that and choose the language that you'd rather listen to. So we have very important presentations and very important analyzers and speakers. So first of all, let me start by thanking you all for coming to this webinar. This webinar starts the week on the week for the prevention of unintended pregnancy in adolescents, and it coincides with International Contraception Day. So, together with FIGO and the European Society for Contraception, the Pan American Health Organization, the Ibero-American Network for Sexual and Reproductive Health, and we decided to get together to work on this that is so important, and it has to do with sexual and reproductive health of adolescents. So now I'm going to give the floor to Silvia Oyserovich, a great friend of ours. She's a gynecologist. She is past president of RPSEF and the Argentinian Society for Child and Adolescent Sexual Health and Reproduction. She was in charge of that topic at the Ministry of Health in Argentina during the period when we worked with ENIA. That is the Prevention of Unintended Pregnancy. It was an extremely successful program that reduced the adolescent pregnancy by 50%. So you already know her. It's a pleasure to present her. Silvia. Thank you, Marisa. I want to thank you all for coming today. Dr. Marisa Labowski, who just introduced me. She's the president of RISHI. She's former past president of the Argentinian Society of Child and Adolescent Health, and member of the Adolescent and Youth Sexual Health Committee of FIGO. I want to thank CLAP and PAHO especially the director of the Latin American Center for Perinatology, Dr. Susan Sarruya, who gave us a scientific support as we're about to hear. And they also gave us support so that this enabled us to be here holding this webinar with all of you. I believe that the speakers have the significance and very relevant in terms of the prevention of adolescent health and the health of adolescent boys and girls. Let me introduce Dr. Sonia Cafe, who has a long-standing experience in the prevention of with adolescents, helping adolescents experience a full life. She's regional advisor to PAHO and adolescent health since 2015, and in the past she works as HIV and STI advisor at PAHO. Sonia has a marvelous career. We were so fortunate to be able to work with her and in Latin America. Sonia, you have the floor.
Thank you very much, Sylvia, for this introduction. And I want to thank you and all the persons who will be presenting for their collaboration and support. I want to start by congratulating you and all the organizers for this important event. For us in the Caribbean and Latin American region, the LARC region, as we mentioned, as we refer to it, the adolescent pregnancy is a very important topic. No, we know, and we say it so often, we have the second highest adolescent birth rate in the world, which is really not acceptable if we compare it with the developmental stages of our economies in the region. We also have the slowest rate of decline globally. And so it is a concern and it is a priority for PAHO. In the global strategy for the health of women, children, and adolescents, adolescent birth rate is listed as an objective for the second objective, as an indicator for the second objective. We know that the global strategy has three objectives: survive, end preventable mortality, thrive, making sure supporting people to reach their full potential, and transforming environments so people can continue to thrive. And so adolescent birth rate is in the second one. And I understand why, because of the enormous impact that adolescent pregnancy has on the lives of the girls, their children, and their communities. But in reality, it also applies to the other objectives. It also applies to survive, because in our region, mortality of adolescents due to causes related to pregnancy, birth, and postpartum is a very important mortality cause. Depending on the year, it can be cause number 5, number 6, but on average, we lose between 700 and 800 adolescent girls due to causes related to maternity. And it is related to transform, because there are environments that continue to perpetuate cycles of adolescent pregnancy from generation to generation. And so it is a complex but very important public health strategy. We have had progress in our region between 2015 and 2021. According to UN estimates, we have achieved over 20% reduction in the adolescent birth rate in Latin America and the Caribbean. But that reduction has not been equal between countries. Some countries, like Argentina, more than others. And also within countries, we see that there are pockets of vulnerable girls who continue to have high adolescent birth rates. And so it is critical that we join forces to implement at scale, ensuring that the most vulnerable girls are reached with evidence-based interventions. And we know that contraceptives are a evidence-based, proven strategy to support this aim. And so I'm very happy with this webinar. And I'm sure some of the questions that many people have will be answered. Some of the questions related to, is it different when you try to reach adolescent girls with contraceptives compared with adult women? How do we ensure that this happens in a context of comprehensive services? So those are some of the questions that people may have, and that I'm sure this webinar will help clarify. How do we improve our strategies, always within a context of comprehensive services and focused on survival, thrive, and transform? And so once again, congratulations. I'm very happy you have a huge audience that only speaks to the expectations of the people. And so I will be listening too, very eager to learn. And so again, once again, thank you for this contribution that will not, I'm sure there are people beyond our region, but that will definitely contribute to strengthening the response in our region. Thank you very much.
Thank you, Sonia, for your incredible words. And well, we continued with this webinar. We have more than 500 people in this webinar from all around the world: Switzerland, Filipinas, United States, Mexico, everywhere. Voy a presentar a la doctora
Let me now
Bombas.
introduce Dr. Teresa Bombas, who's the president of the European Society for Contraception at present. She's a great friend of ours. And as we discussed earlier, we now have a chance to start working together, so many international societies, and to join our efforts. Teresa Bombas works at the local health unit of Coimbra in Portugal, the obstetrics department. She's the president, as I said earlier, of the European Contraception and Sexual and Reproductive Health Society and contraception in Portugal. So, Teresa, let you have the floor. Thank you, Marisa.
It's a pleasure to be here, and I want to congratulate everyone for the organization of this webinar. And I think it's time, because we live in a global world, it's time to join our work, our knowledge, and promote health, reproductive health, and respect the reproductive rights for all. So it's a pleasure to be here, and in my personal name, in the name of European Society of Contraception, thank you for this invitation. So I will present the first speaker. The first speaker will talk about tools for prevention unintended adolescent pregnancy. Is Dr. Rodolfo Gomes Ponce de Leon. I think everyone knows him, but he is a doctor, professor in obstetrician. He works from the 15 years in Pan American Health Organization, and since March 2015, Dr. Gomez has served as regional advisor for sexual and reproductive health at Latin American Center for Perinatology, Humans, and Reproductive Health. He holds a Master on Science in Public Health with a focus on maternal child health from the University of North of Carolina at Carolina Chapel Hill in USA. And since 2007, he is adjunct professor of global maternal health in the Department of Maternal and Child Health at University of North Carolina School of Public Health at Chapel Hill. Rodolfo, it's up to you now, and thank you for accepting this invitation.
Thank you very much indeed for the invitation. I'm honored to participate today. Really, it is a big honor for me to represent the Pan American Health Organization on this webinar. I will switch my language to my native language, that is Spanish. And please, if you are not a Spanish speaker, select interpretation in your own language. Muchas gracias. Entonces voy a solamente en unos breves
Thank
minutos.
you. Just in a few minutes, I'm going to share with you a few thoughts that are very simple, very brief, to be familiar with the webinar framework. At the end of these 10-15 minutes, I would like us to be able to respond to these 4 or 5 questions. What new do we have? What do we have to innovate? What powerful tools do we have in contraception today when we think of adolescence? We want it modern. How long should it last? What is a pill?
Post-pregnancy contraception.
Post-pregnancy contraception. And what does it mean when we say it should be balanced? We shouldn't forget the strong bond that cannot be divided between maternal mortality and contraception. We know that maternal deaths, that 9 out of 10 are perfectly preventable, and we do know how to do it. In our region, in Latin America and the Caribbean, we have a setback of 20 years, not only due to the pandemic, but due to the lack of access. Here we have an example that can only be read in Spanish, but we see a health professional that is being questioned about contraception. She says, contraceptives for you? No, dear. If you don't come with your mom, I can't take care of you. And look at the face of the first in the line. And she says, but no, maybe the blonde in the back, the sexual worker that is the one before the last. And she says, I know, she says, the lady, the one at the end. This truly shows how both teenagers and indigenous women, the indigenous woman in the middle didn't even speak. She's carrying her children, and the sexual worker are quite invisible, transparent to the vision of the health professional that will go to the end of the line to comply with the needs of the health needs of the lady. This is tragic and comic, but true. We may see it in many parts of the world, and particularly in our dear Latin America. We have a report of WHO. If you look at the date, it's prior to the pandemic, where we already see there's this great lack of care needs of women that in a fertile age don't want to have more children and are not using contraception. And look at the face of inequality in this part. Indigenous, Black women, different sorts. Of course, women that use traditional contraceptive methods are also considered as with unmet needs. And we can see this at the end of my presentation, but bear this in mind, it isn't the same to use periodical abstinence as compared to modern contraceptive methods. It's different if you use the method of coming out as compared to modern methods. And I'll share the impact of this in reproduction. Observe that using 2014 data from Uruguay, where you have the perinatal information system that is very well documented for long years, the women are asked about the intent to become pregnant or not. This is part of the clinical record of the SIP, the perinatal information system. The intent of pregnancy has a maximum after 25, 28, 30 years. These are the pregnancies that are sought. And look at the peak of unintended pregnancy. And this occurs throughout the life course, but it has a peak during adolescence. So we are aware that adolescents have this unmet need that is greater as compared to adults. And as Sonia said, within the countries themselves, there's this great inequality. Although at left, you have the fertility rate specific to adolescents according to the quintile of wealth. In green, the wealthier, and in red, the poor ones. The threefold value in the poorer groups as compared to the wealthier. And we have a relative social position also related to the specific fertility rate. A higher social position, the lower the fertility rate, even within one same country. And look here, this is an estimate of the unmet needs for contraception and how they fell in time, but also throughout life. And if we observe, we have different countries, and within one same country, if you take different dates, you have great differences. But these differences also occur among countries. There are greater unmet needs in some countries as compared to others. And if we focus on adolescents at the beginning of this life course analysis, the inequality and disparity regarding unmet needs is great, very great. And as Sonia said, in a developed region as ours, it cannot be accepted. We have this very recent publication from Save the Children that speaks of the younger, vulnerable, unattended adolescents, this group here, that in this analysis show this need to speak of contraception in this circular onion layer model. We have this individual, the family and household, the community, the service delivery and public policies, parenting, access to health services with a capacity to respond to the specific needs of adolescents. But I will now focus on one of these items, as well described by Sonia. We need a comprehensive approach, but we're going to speak of contraception alone. But we have layers to favor the use of modern contraceptions, highly qualified services, and community demanding quality care. Modern and reversible contraception should be easily available to these vulnerable groups. And here you'll have something that you recall, I hope. In blue, in the bars, we show the perfect contraceptive use and the failure percentage. And then the typical use. In the base, you have control of fertility with periodical abstinence with a perfect use. In real life, it has 5% failure. 1/4 of the times that women have sexual relations with periodical abstinence, they may become pregnant. And if you look at the curve of the different methods in the upper part, you have the safer methods. You don't have any method that is 100% effective or with 0% failures, but some are quite close. The tube thumping and the deference of vasectomy have 0.5% failure because there could be rechanneling. And there are some methods that are reversible, and here you have 0.5, and it doesn't depend on the user if they remember they use a method or take an injection or take a pill. But other methods are even more effective. The subdermal implant, that is considered as a modern method after placement, has an error of 0.05, more effective than the tube thumping, and it's reversible. Similarly, the intrauterine device, harpo or progesterone only, that has a failure rate that is even lower than the clamping. And then we have the others, the condom, the male condom, that has a failure rate of close to 2% with perfect use. In real life, it is placed late, is not well lubricated, not well placed, and can reach even 50% failure. So when we speak of contraceptive methods, you have to have this in mind. and for the more vulnerable populations offers the more effective and safer methods. And on the other hand, when you want to reverse, if you see here, we have a number of pregnancies that can be prevented and the cost saved in 5 years. So observe, the most cost-effective are the copper intrauterine device and the implant in spite of the initial high cost. Anyhow, they are the ones that have the best cost effectiveness. And what is the impact of this in the life of adolescents? If we could give all adolescents that don't want to have children, that we know are the majority, a modern contraceptive methods, we would reduce unintended pregnancy 6%, abortions 50% that in our region through the insurance, and close to 67% maternal mortality. This reduction has an impact in the life and development of countries that is huge. But if we think at the econometric point of view, for each extra dollar spent to comply with the contraceptive needs in this adolescent population, the country saves $3.7 in the maternity service costs. So it isn't only defending life and protecting health, reducing changes, but also saves a large amount of money. It is in the same stake because not all methods are at the same level. But as for abortion, we want unsafe abortion to disappear. We don't want it to be necessary. And here's a relationship between the percentage of married women that use modern contraceptive and the number of abortions throughout life. The higher the use of modern contraception, the lower the number of abortions. But the effect is quite unequal when we consider the methods. Taking the same study, 2005, here we have the countries and the name. Each point is a country. And you see that this is always the same. A greater use of modern methods, lower number of abortions. What is the effect of traditional methods? The higher proportion of population with traditional methods, a higher number of abortions of women throughout their life course. So if we want to have a measure of health and reduce abortions, we ought to provide women, and especially the most vulnerable, these modern contraceptive methods. The second item, as mentioned, and there's a special period during the lifetime of adolescents and women in general after an obstetric event, after delivery or abortion, because in Latin America, there is a special characteristic that these two vital situations, delivery and abortion, are mostly over 90% institutional. Therefore, these adolescents went to the institution. We couldn't prevent the first pregnancy, that is multi-causal, and the second, there we have a window to prevent it in contact with the adolescents with the health service. So for this, PAHO and CLAP have designed two things I will briefly tell you. Family planning in 4 languages, in Spanish, French, Portuguese, and English. Takes the model with Global Handbook of WHO. Until last night, we had 76,000 people that had taken the course, and 35,000 had already completed it. And if you look at the map in the middle, it was designed for Latin America. It was considered for the 4 languages of the region, but it's free of charge in the PAHO platform, and it's used throughout the world, Africa, Asia, Europe, and it's mostly young women and health professionals.
The other course is specific in the post-pregnancy. It is much shorter. It also has 4 modules in 4 languages, 6 modules, and around the world there are 46,000 people that have already taken this course, and 28,000 have already passed their final exam. And as you see, it's been used free of charge thanks to the fact that it's available. And then when they finish, they are issued a certificate with the signature of the PAHO director. Some groups have developed on-hand experiences with dummies, and they use postpartum simulators. And we also use empiric practices. While the adolescent is breastfeeding the baby, and together with the partner, this woman is already being inserted an intrauterine device. Here you see this adolescent that has the device in her hand, and she's receiving advice so that she will have decided by the time of her childbirth, even with an informed consent, since the IUD can be inserted within 10 minutes after the expulsion of the placenta. And it is, as a LARC can be inserted right after childbirth. So when we are speaking of contraception, is it licit to continue to say that they're all the same, that all the methods that are available can be left in the hands of the users, of the clients, without helping them decide for the best? The WHO advises a balanced advice going from the safest methods and down to the less effective. And the decision will always be up to the teenager, the adolescent, and her partner. However, when there is evidence showing that one of the methods is more effective, that tends to be prioritized. There are sites, for instance, well, in the HIPs, the high impact practices that are in this website. If you're interested in this, you can visit it and you'll be able to see the specific evidence in terms of how the adolescents access better and using, well, the telemedicine and the community resources, etc. I don't have the time to discuss it now, but this is the QR code for those courses, and within 2 months they are going to be updated. There's going to be a new 2024 version, both of the post pregnancy contraception.
But in the end of all sessions, it will be easier. And so I call the next speaker. The next speaker will talk about practical management of side effects of LARCs, long-acting reversible contraception methods. Dr. Asha Kalisfal. She is consultant and clinical lead in the Community of Gynecology and Reproductive Health in Manchester, UK. She is chair of Contraception Committee from FIGO, and she is immediate past president of the faculty of United Kingdom. Dr. Asha, it's your time.
Thank you very much, Teresa. It's such a pleasure and honor to be speaking today. Especially, it's wonderful that so many of the organizations interested in this field around the world are coming together. We are working closely more and more, and this webinar is just one of the things we are doing together as well. I'm going to share my slides. Please let me know if you're able to see them. Are you able to see my slide? Are you able to see the slide?
Yes, Asha.
Yes.
Okay.
Yes.
Okay. I am not able to see it for some reason. Let me see where it has disappeared.
We can see your slides, Asha.
Oh, okay. Chandra, I for some reason I'm not able to see my own slide, but let me know if it's moving along fine. So I've been asked to speak about practical management of long-acting reversible contraception, how to manage the adverse effects. Now, the previous speaker has really, really well addressed why this is important. So I am going to keep those slides of mine very, very brief. But what I'm going to cover is what are the long-acting reversible methods, the barriers for usage, particularly in adolescents, the side effects and management of that. And then I really want to leave you with a few key messages, which I hope you will find helpful. So he has gone over these, what are long-acting reversible. These are really the most effective methods. And currently in the world, we have hormonal ones, which is the injectable, progestogen-only injectable, progestogen-only implant, the hormonal coils, which in the United Kingdom are 3, with varying amount of hormone in them. Whereas I am aware that in certain countries, there is 1 or 2 of these available. And of course, the copper coils are universally available everywhere in the world. And I won't labor the slide, but as you can see, these are the most effective because they are not user dependent and with very, very high effectiveness and low failure rate. So we know that in the adolescents who choose to have them, they find that they are very effective, they have high continuation rates and also very high satisfaction rates. Unfortunately, though, studies are showing that in the teens, they remain very low, 2 to 3%. And we also know that a high percentage of young women miss the pill. This is one survey, but this is replicated in other surveys too. So it is really important that if we are looking to provide a good method of contraception, we need to be making sure that they have access to LARC, and we try and remove any barriers to the use of LARC. So what are these barriers? In young people in particular, you see that there is a less familiarity or understanding about the LARC. I'm sorry, somebody is saying they cannot see the text. Can you confirm to me that the slides are visible, please?
No, yes, Asha, are okay. We can see it.
Yeah, okay.
Yes.
Thank you.
Perfect.
The slides are visible and we now have barriers to use of LARC as the title.
Yeah, absolutely. It's just that in the chat, someone's saying I can't see them. That's why I wanted to recheck. Thank you. So the barriers include lack of an understanding or familiarity with what LARCs are. Of course, access is a big problem in so many countries worldwide, isn't it? Sometimes the access is not just because of infrastructure problem, but because healthcare providers have their own kind of myths and knowledge gaps. Sometimes adolescents are with their parents, living with their parents, and the parents are not very keen on these LARC methods. And sometimes it is just a lack of understanding that maybe it is discomfort rather than pain. Analgesia is available for fitting of some of these methods because social media is such a big thing today and youngsters are on social media. And sometimes, it is a self-selected group of people who will highlight the problems rather than the benefits. So how do you overcome these barriers? And counseling, and throughout my talk today, I'm going to emphasize that how we counsel youngsters is the key to providing them with the best method for them. Expectation setting is so important. If they are aware that, for example, they're going to have irregular bleeding initially, they are intelligent people. They are much better able to cope with what they know is going to happen rather than that happening suddenly without proper counseling. And adolescent-friendly clinics in the UK, we have your welcome criteria where clinics, young people-friendly clinics are assessed on these criteria. But the previous speaker showed some beautiful slides around how making them feel welcome is so important. So is myth busting, making sure that they are aware. For example, a lot of healthcare professionals, but a lot of people out there, lay people also think that coils cannot be used in somebody who hasn't had a child. Now, that is just not true. And it's really important that we give the right messages. We have the own us, we have the right training and give the right messages. And we need to be sensitive to their needs. Quite often, you know, when I'm fitting a coil in a 17, 18-year-old, I'm aware that this is the first examination they're having, and to be sensitive to that, explain. I know we explain to everybody, we take consent, verbal consent or written. However, in these cases, it's really go that little extra mile. And I think the most important thing is for us to reassure them that if they don't like the method, we would jump in and take it out. A little bit more about counseling, because it is so key. It's important if they're under 60, for example. In our country, we have Fraser guidelines that we document everything. We make sure they understand. They need to be told about all methods, not just LARC, but it's important that when we talk about side effects, we also talk about the benefits. We are try and understand what concerns they have and try and address those concerns. There is some good guidance available. The Faculty of Sexual and Reproductive Health from UK, the guidance is free of charge. It is accessible to anybody. And I have picked up these two because I have read quite a lot from this guidance I have used for my presentation, but also we use the WHO medical eligibility criteria because age alone is not a barrier to any method, but sometimes medical conditions may be. Okay, let's move on to each of these and managing side effects. So progestogen only injectables in UK, we have these two, an intramuscular one and a subcutaneous, which can be self-injected. It is different around the world. I'm very, I know that, but some countries will have both. Some countries will have a physician-injected Depo-Provera that is more commonly available. And this can lead to hormonal side effects of weight gain, low mood, headaches, breast pain, acne. The jury is still out on whether they affect bones. And also in many women, it can delay return to fertility. So management will be again counseling, because bleeding is common in the first 3 to 6 months, and so is so are the hormonal side effects. So if they know that they are likely to settle down, they may cope with it. Lifestyle measures to improve bone strength. If they are planning a pregnancy, they need to know that they may take longer. And at the end of the day, you know, sometimes if the hormonal side effects are too bad, you may have to change the method. Bleeding patterns are irregular commonly in the first 3 to 6 months. Only 1 in 10 will have no periods straight away. But 50 to 75%, look, you know, most will have no periods by the end of 12 months. And I will discuss more around how to manage the bleeding altogether, because it's quite common. However, for all the hormonal LARCs. However, if the bleeding is in the 3rd month, you may want to give the next dose early, after 10 weeks. Progestogen only implants. So Jadel and Lexplanon are the commonest one. Jadel is 2 rods, Lexplanon is 1 rod. The National Institute of Clinical Excellence in UK, they have said that Implanon is not associated with weight gain, mood changes, headaches, or it affect libido. Sometimes patients will come with this, and even though you say that if they are feeling those side effects, it's very, very difficult to say to them, no, it's not your implant. And sometimes taking it out and changing to a different method may help them. Acne can improve or worsen with this. There are other problems can happen with the progestogen only implant. So you can get infection at the site or scarring, a hematoma, you might have to drain. Infection you will treat with antibiotics. Sometimes, even though it has been fitted correctly, you may find that the implant is impalpable. What do you do in such cases? A specialist center will do, like ours, will do an ultrasound and try and locate it. If we can't, We will do a etonogestrel assay and check whether it is even in the body or it has been extruded by any chance. And then you can need further imaging as well. For example, an X-ray to locate it or a CT scan, but that you would leave it to a specialist center such as ours. Broken implant is much more common, and sometimes it is because they've been playing with it, or sometimes we don't know why it has happened. Now, the manufacturers are quite happy that efficacy is not affected. However, it is so important, isn't it, to talk to the young person, and you can just discuss it with them and say, what do you want to do? We know it's working, and at the end of the day, if they insist, then just replace it. The bleeding pattern, common again in the first 3 to 6 months, irregular bleeding, and then settles in 50% of people. 1 in 5 have no periods at all. 1 in 5 have frequent and prolonged periods. However, it is the bleeding and spotting days are lower. The problem is really because it's unpredictable. It's the unpredictability that people don't like. And that is the reason for discontinuation. 1 in 3 is due to an irregular, unpredictable bleeding, less than 10% for other reasons, including hormonal. Let's move on to the hormone coils. There are 3 that are available: the Mirena or similar Benelux Levocert. These are 52 milligram coils. And then there are the 2 small ones, Kylena and Jadis, 19.5 and 13.5 milligrams. And these are 5 years and 3 years, respectively, based on the amount of hormone in them. And look at the bleeding pattern. You can see that this is at the end of 90 days. With all of them, you get much less bleeding, and the spotting can vary in the 3, with the Mirena with the best profile, of course. So usually settles by 6 months. And as if you have the higher 52 milligram one, 90% reduction in menstrual loss over 12 months. Very few 1 in 5 end up with infrequent bleeds. With the others, you get lighter periods. 18% stop their periods with the Kylena, and 12% with the Jadis because they have less hormone. Hormone side effects can occur, but the amount in your blood is very, very low. So for example, with the Mirena, we tell patients that it is a quarter of a mini pill, of a progestogen-only pill. So most people tolerate it quite well. It's difficult to confirm a causative effect. However, again, if the symptoms persist after the first few months, it's reasonable for us to say, okay, let's think about a different method. A copper coil is universally used all around the world. Very, very effective method of contraception. In the first 3 months, periods can become heavier, intermenstrual bleeding can occur, usually settles down. If it doesn't, you can offer them a low hormone coil like Kylena or Jadis. What about the adverse effects of the copper and Levonorge, any coil? So I have bunched these 2 slides together because these are common to everybody. So pregnancy, risk of pregnancy is very low, as you've seen from my earlier slide. But if there is a positive pregnancy test, it's really important to do early assessment and make sure it's not an ectopic pregnancy. Not because it caused it, but because it may not have prevented it. And if the woman is less than 12 weeks pregnant and the threads are visible, it is really important to try and take it out to improve pregnancy outcome, particularly if they want to continue with the pregnancy. What about pelvic inflammatory disease? The risk is again very low, more related to them having chlamydia, gonorrhea, or a STI. However, it's commoner in the first 3 weeks when the coil is fitted. Give antibiotic treatment and review in 48 to 72 hours. Some people are really quick to take the coil out. Please don't do that because you may expose the woman to a pregnancy. If the clinical condition improves, there's no reason not to continue with the coil. whichever it is, the hormone or non-hormone. Non-visible threads, again, almost 1 in 5 will have no threads, which can be due to expulsion, which is again 1 in 20, pregnancy, less than 1 in 100, or perforations are rare, 1 to 2 in 1,000. So first of all, exclude pregnancy, and we've discussed already how the pregnancy will be managed. Make sure you provide alternative contraception and arrange an ultrasound scan. If on the scan you don't see the coil, it's really important to do an X-ray. Not assume it has been expelled, but do an X-ray to see if it is perforated and somewhere in the abdomen. And make sure to include the diaphragm in the X-ray, because sometimes they can just go and sit under the diaphragm. If it is correctly sited, there is no need to try and take it out. You can reassure the user and it can be left in for its lifetime. Perforation will need laparoscopy or laparotomy for removal, and then wait at least 6 weeks, because sometimes women will come back and say, I still want a coil. Risk is 1 to 2 in 1,000. Unlikely it'll happen again, but wait before, let everything heal properly. And, you might want to do it under ultrasound guidance. What about malposition? Sometimes, you get these scans, either you've done the scan because threads are not visible, or you may have done it for a totally different reason. And if you find, that it is less than 2 centimeters from the fundus, there is good evidence that it is still effective. However, as always, you can offer replacement if required. Okay, this is the last little bit I want to do. I'm doing it together, the bleeding problem, rather than, the same thing with each of the methods. So taking a detailed history is so important. What is the pattern of bleeding? What is her concern with it? Has the method run out? Is that why she's bleeding? Is it heavy? Are there any other symptoms? Does she have pelvic infection? Something else that is happening there? Is there a risk of a sexually transmitted infection? And rule out, is there a drug interaction causing the bleeding? Or is she pregnant? And consider, obviously, testing for sexually transmitted infection. Generally, you don't need to examine them very quickly unless there is pain or you think she may have pelvic inflammatory disease. But after 3 to 6 months, with an implant and the levonorgestrel IUD, you could even wait up to 6 months, because that bleeding can last that long, irregular bleeding. But otherwise, examine them, and treat accordingly. How do you manage the bleeding with the hormonal LARC? In majority of cases, the bleeding settles, and just reassurance is all that is needed. First-line treatment could be the combined oral contraceptive pill if not contraindicated. And it can be taken continuously for 2 or 3 months. Longer term, you might wonder why are they using both methods then? And you can have a discussion with them. If it is heavy, the bleeding, you could use tranexamic acid or, an NSAID for 5 days, like mefenamic acid is one we like to use quite often. Second-line treatment could be giving Provera or norethisterone tablets for 3 weeks and seeing whether it settles down. Okay, I want to leave you with some key messages. LARC should be offered as first-line method to all adolescents. Bleeding is common, and we've discussed how to manage the bleeding. Counseling is key. But please remember, however much we want to promote LARC, the best contraceptive choice for the adolescent is the one that they are willing to use. Thank you very much.
Thank you, Dr. Asha. I think we can leave all the questions for the end. And I will call the next and the next speaker. That is Dr. Chandra Molly, Dr. Chandra Moli is formerly a scientist, adolescent and sexual and reproductive health on the Department of Sexual and Reproductive Health and Research from WHO. Currently, he is independent adolescent sexual and reproductive health and rights learner, communicator, advisor, teacher, and support advocacy, research, and action. Thank you for coming. And it's your time now. You will talk us about where are we on comprehensive sexuality education 30 years since the International Conference on Population and Development. Thank you, Dr. Chandra.
Thank you, Madam Chair. Can you please confirm that you can hear me and see my slide?
We can see and
Yes.
the confirmation. And
Yes,
more than welcome,
everything-
Chandra.
Everything is perfect, Dr. Chandra.
Thank you very much. I've just listened to the presentations by Rodolfo and Asha, and so I'm going to build on that and speak about sexuality education. I have been introduced, and so I will skip this slide. Before I go into my subject, I'd like to recall that the International Conference on Population and Development, which was held 30 years ago, was a landmark event in sexual and reproductive health and rights. It placed women and girls and reproductive health and rights as on the agenda, but from the perspective of adolescent sexual and reproductive health, it was the first time that it placed this particular issue on the global agenda. And 30 years from the ICPD, we have a lot of things to celebrate. And that's not the subject of my presentation, but I have 3 slides on this because it's important to celebrate success. When we speak about adolescent sexual and reproductive health, we often speak about problems and gaps and challenges. But 30 years after the ICPD, adolescent girls around the world are less likely to be married, less likely to be mothers before the age of 18, less likely to have experienced female genital mutilation, less likely to get infected with HIV and to die from HIV-related illnesses, and that includes in the poorest countries of the world. And adolescents are much more likely to have to be using all these reproductive health services and commodities that I have listed on this slide. While there is progress, it is slow and it is uneven, but progress that is happening is undeniable. We've just published a paper in the Journal of Adolescent Health, Trends in Adolescent Health, Successes and Challenges from 2010 to the present. There's been no progress in some areas of sexual and reproductive health, such as sexually transmitted infections outside HIV, gender-based violence. But an important point to note is that there has been almost no progress in any of these other areas outside sexual and reproductive health. Depression and anxiety, loneliness, injuries and violence, overweight and obesity. The bottom line message is that the areas that we as a global community worked on over 30 years, without knowing exactly what to do, in a messy way, making mistakes as we did, has together contributed to progress. None of the other areas that we have not worked on have made progress. STIs, gender-based violence, mental health, etc. There are important implications of this, but the important implication of this, one important implication, is that when we work together, we can make change. And that is a positive message to take over. The glass is not full, but neither is it empty. Let me now move to the subject of my presentation. I have deliberately used the word sexuality education, not comprehensive sexuality education, for 2 reasons. One is that, in many countries, very different terms are used. Although we in the UN like to use the term comprehensive sexuality education, many countries avoid the use of the term because of the risks of resistance. And secondly, a UN report that WHO and other agencies contributed to noted that most countries, even countries in Western Europe, liberal democracies like Sweden and Netherlands, their programs were not completely comprehensive. So we are all in a journey towards comprehensive sexuality education. I'm going to make 5 points in the next 15 minutes. First point is that there is solid evidence that children and adolescents need sexuality education, and that when sexuality education is well designed and well delivered, it is effective in achieving the outcomes listed on this slide. There's also convincing evidence that it does not harm, that it can be scaled up and sustained, and it is cost effective. There is a large and growing body of program support tools for advocacy, planning, management, monitoring, review, and evaluation. The strong evidence, there are the Fauna Review and the Goldfarb Review are reviews that we cite consistently in the literature, which have looked at evidence from randomized controlled trials, from quasi-experimental studies, and have put together the message that sexuality education is effective. But what about data from countries? Maybe you've not seen this data, and I'm very happy to share with you similar studies from Sweden and Netherlands. Germany has had a sexuality education program for over 50 years now. And every few years, they do a youth sexuality survey. From the 9th iteration of the youth sexuality survey, this is the trends. What they say, the concluding message, is that contraceptive behavior among young people is largely safe. So what you see here is the levels over, young people start using contraception early. The use of contraception increases with time. And most importantly, when they have sex, they plan to have that sex, and it's not a surprise. And most people recall that this first sexual experience was a pleasurable one. You will see in this slide, and if you see in the 2019 bar in figure 5, the proportion of adolescents who do not use contraception during the first time has increased slightly between 2014 and 2019. And this is something worrying, but this is also one of the questions of consequences of the COVID pandemic and its aftermath. But overall, large-scale sexuality education programs do not lead to early and increased and more risky sexual behavior. It actually prepares young people for a safe and happy and pleasurable sexual and reproductive life. So we have evidence on effectiveness, cost effectiveness, on scaling up tools, and sexuality education has been included in a number of international and regional commitments. One example, of course, is your Montevideo Consensus, but there are similar consensus documents in Eastern and Southern Africa, and most recently last year in Western Central Africa. And with every step in the process, these commitments have become stronger, and the accountability mechanisms have really got teeth now. My second of 5 points. Sexuality education is increasingly present in national policies, strategies, and guidelines. Curricular reviews show that content generally is watered down, it's too little, it's often too late, and it does not match students' interests. Research studies and evaluations show poor fidelity and quality of school-based sexuality education. The journey towards comprehensive sexuality education, the Global Status Report, which I mentioned earlier, says that data from 155 countries that report that the majority of countries have laws, policies related to sexuality education. So favorable policies by and large, but a gap between policy and implementation. And that is, this is the summary of that report. And I'm not going to take you through all the points in this slide. Essentially, what I'm going to make is that there is most countries incorporate sexuality education, but in reality, only the biological aspects. Issues such as, how do I deal with this boy who's making advances towards me and I'm not happy with that? Or I'm interested in this boy. Is it okay for a girl to make the advance? Those kinds of issues are never discussed. And that's really what kids want to discuss. Relationships, the social challenges, not really the cross-section of the vas deferens and the structure of the fallopian tubes. In terms of practical implementation, what you see is this is a study from Ghana. What you see is a huge problem is that teachers face challenges in teaching about sexuality education. They don't have the resources, they don't have the time, and they're uncomfortable in discussing this. And of course, you can't suddenly start talking about masturbation and menstruation after a trigonometry lesson and feel completely comfortable about doing that. Clearly, much more needs to be done to build consensus, but work is needed in this area. My third point is that the focus of sexuality education has evolved from population control through HIV prevention to sexual and reproductive health. And increasingly, it's beginning to embrace justice, sexual and reproductive rights and justice. Champions for sexuality education are pressing for greater and more inclusive content. On the other hand, opponents are pulling in the opposite direction. This is from England. England has statutory sexuality education from 2020. A study by a group in England found that essentially boys are not interested in what is happening. They're kind of walking away and saying this is something that this is something that relates particularly to girls. And there is no discussion about issues that this group believes is important, which is domestic abuse, healthy relationships, controlling behavior, the whole discussion of consent. And what do you mean by consent and how is consent operationalized is a big challenge. And as you can see, there are many things that these kids want to have done better. They say that it's rushed, a discussion is awkward, on sensitive matters, teachers are uncomfortable to teach. And that's true in India, the country I come from. Over the years, the content has got watered down and watered down and watered down. This is the review of the content of the curriculum. Curriculum content does not talk about sex or sexual relationships or discussions on romantic relationships is sparse. So what is it then? Essentially, it's like hand washing, keeping your hands washed clean with soap and water. All the important issues are not discussed in curriculum because people who formulate curricula are scared to say things because they're scared of backlash, as has happened in India and has happened last year in England. So everywhere in the global south and the global north, we face this, we are kind of, we are ourselves cutting down on content because we are scared about the backlash. My fourth point, discomfort with and resistance to sexuality education is not new. What is new is that it is better organized, well-funded, and more assertive. It is also part of a globally connected pushback on various aspects of sexuality, education, and sexual and reproductive health and rights. This is a wonderful document published by IPAS called False Pretenses, the Anti-Comprehensive Sexuality Education Agenda, Weaponizing Human Rights. And essentially, their message is that because sexuality education is high on the agenda, this has now become a huge target. And what you see is a direct connection between right-wing evangelical groups in North America and the law on homosexuality in Uganda. There's a clear trail in this. And this trail in Ghana, this trail now in India and the whole fight against sexuality education last year in England, you can track this, and that's why it's so important that Kamala Harris wins this election. What is happening for the young people in the US, but for the young people of the whole world. We really need the poison coming out of the US to somehow be stemmed. WHO is standing up to this, but let me come to my last point. A small but growing number of countries are scaling up, sustaining, and enhancing school-based sexuality education programs. And this is good, and we need to celebrate this, as I've done in this paper, which I will share with you. But we must also recognize that there are huge numbers of young people who are out of school. Although school enrollment is increasing, there are still many people, particularly in the higher secondary school, who are out of school, and they need to be reached. In May this year, I'm 66 years old. I completed my PhD in the University of Ghent on scaling up, sustaining, and enhancing school-based sexuality education programs. And this paper was published in the American Journal of Sexuality Education. I'm very happy to talk to any of you who are interested for more details. But here, just 3 slides on this, and as I close. There are countries in resource-constrained and conservative contexts that have scaled up, sustained, and enhanced their sexuality education programs. You will see that I put Uruguay there. Uruguay is by no means resource-constrained. Yes, I mean, if you compare it with the richest countries of the world, but they have resources. I mean, you can't compare Uruguay and Pakistan in the same breath. But there are countries that have scaled up, sustained, and enhanced sexuality education programs. And they did this by doing 6 things. They placed scale up on the national agenda. They planned the scale up meticulously. They secured funding for scale up from within and without. They used data and implementation experience to inform the scale up and to shape its evolution. They promoted and safeguarded its sustainability, and they worked hard to deepen and extend support and to learn to anticipate and respond to resistance. I'm going to share one example of this from Pakistan. The approaches they used were mostly not new. What they did was they brought these approaches together and doggedly pursued it. Mexico, for instance, sexuality education program for over 30 years. But, maybe it's easy to have these approaches in Latin America. But, a country like Pakistan, an Islamic country, struggling with growing Islamic fundamentalism, but over 20 years, step by step, like a snake and ladders game, they've gone. 3 steps forward, 5 steps back, 2 steps forward, 1 step back. And they've used approaches. I'm just going to give you one example of what they did. The case of Zainab in 2017. A little young girl was brutally raped in Punjab, in Pakistan. There was an outcry and a call for action. The whole network of NGOs working on sexuality education said, we can offer an alternative. We need to protect girls and inform girls so that if anything happens to them, they can ask for help. They know how to resist themselves. It is now being scaled up in Sindh, in Balochistan, and through a step-by-step process, it is being scaled up. So they've used entry points and moved forward. This slide just makes the point that we should not forget those who are out of school. And there are programs such as the Global Program on Child Marriage, which are doing that. To conclude, in the 30 years since the ICPD, the world has been transformed. Sexual and reproductive health has improved overall in the areas addressed by the ICPD, but there are groups left behind, and there's much more to be done. Secondly, there's growing consensus that sexuality education is needed, that it helps and does not harm, and that it needs to be delivered using scientific curricula and delivered from home to school to community. Thirdly, a growing number of countries are delivering sexuality education in school, but the quality of what is being delivered in content and delivery needs to be improved. Fourthly, valuable lessons are being learned And we need to move from projects to programs and reach those young people outside school. Finally, resistance to sexuality education has always been there, but it's getting stronger, more organized, more resourced. And we need to stand up and respond to this in a proactive way and in an assertive way, so that it and not get intimidated by this, because we have to stand up and fight in every corner, including in northern and Western liberal democracies. Last year, the Netherlands had a huge attack on sexuality education. So this is not just a problem of Bolivia and Uganda and India. This is really a global problem that we have to stand up to. Thank you very much, and thank you for your patience. Very happy to continue this discussion with anyone who's interested, and namaste.
Thank you, Dr. Chandra. Now, I think we have time for some questions. I call for moderation of the questions Dr. Gabriela Perrotta. Dr. Gabriela Perrotta is undergraduate and postgraduate professor at University of Buenos Aires. She's past technical coordinator of the Directorate of Sexual and Reproductive Health on National Ministry of Health on Argentina, and she is member of scientific committee from Sajid and Amada. Gabriela?
Muchas gracias, Teresa.
We have some questions
Thank
on
you.
chat, and
Tenemos
I think we will have with her Susana and Veronica Fiol also.
Sí, voy a presentar a nuestras compañeras. Primero les
Yes, I'm
saludo.
going to introduce our colleagues. First, greetings, and thank you to all who have made their presentations. Thank you for coming.
Un honor y un placer
It's an honor and pleasure
presentar además a mis
to introduce
compañeras
my colleagues
comentadoras.
who
Voy a
will
presentar a la doctora
share the
Susana
comments. First, Dr.
Nisnanska,
Susana
médica,
Nisnanska.
PhD
She's a
en
physician. She
FEPA,
has a
es
PhD
docente en la
in FEPA.
Facultad de Medicina
She is a
en
teacher at the School of
Men's
Medicine
University en
in
Bratislava. Es la
Bratislava.
presidenta de la Sociedad
She's
Eslovaca de
president of the
Ginecología Pediátrica
Slovakian
y Adolescente,
Pediatric
miembro del board de la
Gynecology and
Sociedad
Adolescent
Eslovaca de
Society.
Contracepción
She's a member of the
Endometriosis,
Contraception and
vicepresidenta del
Endometriosis
URAPAC
Society,
y
vice
miembro
president
del
of
board de
URAPAC, and member of the
La
Fiji
doctora Verónica
board.
Fiol es
Dr. Veronica
ginecóloga,
Fiol is a
profesora de grado de
gynecologist. She's a
clínica
teacher
ginecológica de la
of
Facultad de Medicina
gynecological
del
clinics
UDELAR,
in School of Medicine at
consultora en salud
UDELAR,
sexual y
consultant in
reproductiva de
sexual and
TAP-APS,
reproductive health in
expresidenta de la
TAP-PAHO,
Sociedad
former
Uruguaya de
president
Salud Sexual y
of the
Reproductiva y es la
Uruguayan Sexual and
presidenta
Reproductive Health
actual de
Society and
RINSEP.
current president of RINSEP.
A mí me gustaría solo
I would
para
like to
iniciar este espacio
start
de
this
comentarios
space
que le
for
voy a pedir
questions
a
and
mis
answers
compañeras, a
and
Susana y a
comments, and I'm going
Verónica
to ask
también
my colleagues
que hagan
Suzanne
un
and
breve
Veronica
comentario
to
sobre las
make a brief
presentaciones
comment
para
on the
introducir a las
presentations, to
preguntas.
introduce questions,
Y lo que quiero es
and
retomar de las
I want to pick up
exposiciones la
once
importancia
again
de
the
garantizar los
importance
derechos
of
sexuales y los
guaranteeing
derechos reproductivos
sexual and
y
reproductive
especialmente hoy nos
rights.
convoca
We're
la anticoncepción
called
en
on
adolescentes
today
para
to speak of
pensar
contraception
las
in
estrategias para
adolescents, to think
reducir
about the
el embarazo
strategies
en
to reduce
adolescentes y que
pregnancy
lo que nos has
in
compartido
adolescents.
es
And
que
what we've
esa
heard is that
reducción
this
posible no es la
possible
misma, no ha sido
reduction
la misma en los
hasn't
diferentes
been
países
homogeneous in the
y
different
tampoco al
countries,
interior de los países muchas
and even
veces.
within countries
Tampoco el acceso al
oftentimes.
aborto seguro es
Access
equitativo.
to safe
Entonces,
abortion isn't
partamos de
equitable
la
either.
base de
So let's
políticas
start from the
públicas
basis
necesarias para
of the
garantizar el
necessary
poder de
public
todas las
policies
personas,
to guarantee the
especialmente las
right of all,
vulnerables.
particularly the more
Y nos han
vulnerable people.
propuesto
And the
un enfoque
proposal has
integral,
been a
pero en este
comprehensive
caso
approach.
han
But
hecho
in this
hincapié
case, people
en
have
la
stressed
información,
information,
la educación sexual
including
integral
comprehensive sexuality education
moderna,
and modern
sobre todo haciendo
contraception,
hincapié en
particularly
LARCs
stressing
y en la
LARCs
contracepción inmediata post-evento
and
obstétrico
immediate
como fundamentales para
post-obstetric event
garantizar estos
contraception
derechos,
is
tanto
fundamental
para
to
reducir
guarantee
el
these
embarazo no
rights,
intencional en
both to
adolescencia
reduce
como para
unintended
garantizar
pregnancy
el
in
embarazo
adolescents
seguro.
and to
Les
guarantee
pido
safe
a
abortion.
Susana y a
Please,
Verónica
Susanna
si
and
quieren
Veronica,
hacer algún comentario
if
en
you wish to
particular
make
para
any specific
iniciar
comment to
las respuestas a las preguntas que han hecho quienes han
initiate the
participado.
Q&A session.
Susana.
Susanna?
Okay, first of all, hello everyone. Thank you for this privilege to have opportunity to be here with you, because it was really wonderful session. There were great lessons. We heard so many informations. It is very difficult to comment it. I just like some my observation I would like to add. First of all, for the first lecture, Dr. Rodolfo explained everything excellent. If we talk about adolescent pregnancy, that my point of view is that it is not only about that what can happen during pregnancy and how dangerous is that course of pregnancy in adolescent age. And also for delivery, but it is also what will be in the future with those adolescent parents. How will they live? What will happen with them? And also about the future of that child of adolescent parents, because we know that they are more likely to have some poor school performance. They have much worse results in the school, in their education, and also in their future. And they are also more likely to copy that from their parents. So that means that we let build the next generation, which has not good points at the very beginning. So this is that. If we go to the data of WHO, so that we see that we have 21 million adolescent pregnancies per year, and more than 50% finishes with abortions, which is also not safe for girls and for their future and for their reproductive health. And we have still 12 million of birth in adolescent age. That means that risk is still that. So what do we need really is the perfect knowledge about the tools, predominantly about contraception, and it was enhanced. And congratulations that this is really in the very affected region of Latin America, that there are so many nice programs developed for education. The effort is to do it all over the world, but the terms and conditions are very, very different, and sometimes it is very difficult, as I see it in Europe, and especially in Eastern Europe, where that attitude to contraception and all these matters is a little bit different. And this could be also comment to the last lecture of Dr. Chandra Muli, because we have to we really, as you enhanced this, we have to create reliable sources for education, reliable educational program, not to let adolescents to search on their own. And as we had the discussion with Marisa Labowski yesterday on Polish conference online, so the generation that need that education from us is completely different from generations before. So there is a lot we have to learn on our own to be able to teach the generation, the young generation, what to do and how to do. And this is not only about, we know about contraception, but this is predominantly about that we know how to approach them and how to attract them to care for themselves in these terms. And with this, it is very important to know about the practical points. And then thank you, Dr. Asha, for your very practical lecture, because it is very important to know about that long-acting contraception should be the first line for adolescents, because it is much more difficult to discontinue when it is not necessary, and it is necessary to decide. And this is also very different. How do we approach it in different regions? Because still we have regions when there is very, very reserved and very careful in these terms. So this is that. So thank you for the practical attitude toward that. And there should be I think there should be a lot of questions, or there could be a lot of questions about that, because it is very important for that. So thank you very much, and I leave the floor for Veronica now.
Thank you, Susana. Verónica, por favor.
Hola, ¿qué tal?
Veronica, please. Hello.
Buen día, buenas noches, buenas
Good
tardes.
morning, afternoon, evening. As Marisi said early on, it's a pleasure really to participate in this seminar. I first wish to really thank the speakers for their presentation.
Estoy en este seminario en un rol múltiple.
I am playing a multiple role here. I'm a member of CLAP, the Latin American Perinatology Center, PAHO, and I work together with Rodolfo in the sexual and reproductive health area, but also as president of REDISA, the Ibero-American network of sexual and reproductive rights professionals. And it's very important to be here because one of the strengths I think we have as a network that we share with PAHO is this matter of being able to make the most and learn together from each other, being able to share success experiences in each of our countries, I believe, being able to learn. Well, I come from Uruguay. I'm Uruguayan. I'm very happy to hear about my country as an example in some areas related with health and sexual and reproductive rights. But it's also true that there's much to be done still, that rights are always present, but always threatened. If we think that some rights have been already won, something may occur and we may lose them. And it's important, I think, to build upon these processes, and professional meetings are essential here. Briefly, I wanted to say something I think is important in adolescent contraception that goes hand in hand with adolescent pregnancies. It's hard to speak of contraception without speaking of pregnancy. And that's an issue also because we place contraception within reproductive health, and it's sexual health that's really important. We want separating contraception from pregnancy is perhaps a major challenge. Maybe including contraception within sexuality, and not only speaking about contraception to prevent pregnancy. No, let's have an important contraception policy to have a very full and enjoyable sexuality. Of course, adolescent pregnancies is very important, and it's important to discriminate the two major sorts of adolescent pregnancy because the causes and root causes are different. In adolescents over 15 years, pregnancy has certain features. It's related to sexual education and the social and cultural environment where adolescents, both female and male, non-binary identities are managed. And then we have this great group of those under 15 and infantile pregnancy. I think we cannot speak of contraception there alone. We must speak of violence and the importance of managing other aspects and not only related with contraception. So I think that maybe there, I will go to the last presentation by Dr. Chandra, because it is there that we must begin to work in the perception of the role that people have in the care and self-care of our own sexuality. People have extreme vulnerability where knowing maybe up to what point we may be impacted by the actions of others, and adults in particular that are close by is very important. So it is there where he starts. Where are we going with sexuality education? To school, to secondary schools, or elsewhere? to the social media. Let's work with peers. In Uruguay, we have this small and relatively metropolitan experience of this initiative that's called Sexuality Without Faith. We work directly with adolescents, and it's related with that. Sexual health from adolescents to adolescents, from youth to youth. I think that it is there we must try to reach this diversification of sexuality education. We must not only include this informal education and include also in peer education, social media. Speaking of education without the social media is very important. I'll stop here because I think it's important, but I'm open for any question related with our IPOEC strategy we use in CLAP and that Rodolfo introduced in a very exhaustive way. And of course, the importance of the biological aspects, management of long-acting methods and side effects. So, thank you once again for allowing me to speak to you.
Gracias, Verónica. Bueno, nos hemos extendido bastante. Tenemos una serie de preguntas, pero la verdad es que la mayoría de las
Thank you,
preguntas...
Veronica. Well, we have many questions, but actually many of them were already addressed by the speakers and also by the comments of Susana and Veronica, so I'm going to pick just some of them, mostly to highlight what we are interested in highlighting today that has a lot to do with what Veronica just said. There are some specific questions that have to do with implants, with insertion, and how to remove it, but especially the first questions have to do with the need to provide more comprehensive sexual education and how to promote more education programs by governments, which would be the main strategy to be implemented to prevent early pregnancy in adolescents. And I think that Veronica and Chandra could address that. What would be the best current strategies so that patients may become aware of how important it is to use a method? Because our healthcare center is a private center. Most patients have sexual education, and yet we do not make them aware of the risks. And what is the role of the education centers to reduce pregnancy rates among adolescents, and what are the best strategies? So let me repeat, I think that some of them have been answered, but especially Chandra and Veronica, if you wanted to address some of the ideas or access to stress what we are interested in sharing today with the participants. Chandra?
Thank you, my friends. Yo puedo hablar en español, pero es muy difícil.
I can speak English, but it's very difficult for me in a situation as today.
Tres cosas.
You have simultaneous translation.
I think the first point is, I've just come from Kathmandu. I'm actually speaking to you from the airport in Bangalore. Tomorrow, on the 23rd, my mother will celebrate her 95th birthday. So I have come to join in family celebrations for that. So I was in a 3-day meeting of ministers of health and education, ministries of health and education, not ministers, of South Asian countries in Kathmandu. And, I am from India, so I was able to tell them that, and this meeting was about making health systems responsive to the needs of adolescents, to talk about contraception. And in many of the countries of the South Asia region, they don't talk about unmarried adolescents. It's difficult to talk about it. And the only way to deal with it is to get champions to speak about this. I told them that I had sex before I was married. I went to a pharmacy far away from home. and to get a to get condoms, waited there till everybody left and then asked for it sheepishly. Sometimes I was thrown out, and sometimes I got it and walked out feeling like a king. Once I had developed their confidence, I also told them once, I'm happily married, I have a lovely wife, we have a wonderful sex life, but I masturbate from time to time. What about you? And I said, perhaps many of you in the room do. I think the issue is we have to normalize sexuality. We have to challenge people to think about these issues, and we have to personalize it because everyone thinks about sex as the other person's issue. And I think, the only way to deal with this is to get champions from within countries and to get this discussion going. My second point is take England. England has for many years championed sexuality education in many parts of the world for over 10 years, 15 years. But England had statutory sexuality education only from 2020. So in England itself, they didn't have sexuality education, but they were championing sexuality education in Uganda and Malawi and India and Pakistan. So, and last year, the prime minister, a weak prime minister, with pushback, he kind of accepted to the pushback on sexuality education. So this is a challenge everywhere. And the only way we have seen it works is champions in the country who are supported from outside, who can move the field forward. This lady from Uruguay said Uruguay has a lot to learn and a lot to move forward. But you know what happened in Brazil. It was one of the most progressive countries in your region. And, under this, under right-wing government, they stripped all the municipalities of their anything to do with gender. So yes, there will be progress, and we have to talk about sexuality. We have to talk about it, but we have to accept that it will not be easy. We have to move forward. We have to regroup and come back. It's happening now in Argentina with this president. And what can you do? You have to accept it. You have to regroup. And, hopefully when he goes away, we have to come back and build what we have built and strengthened. That's all I can say. I think we need to do it, and we need to do it in conservative countries. And what I've learned after 30 years in WHO is we can only play a supportive role for champions from within the country. If there are champions within the country, we can support them and strengthen their hand. Thank you.
Muchas gracias, Chandra.
Thank you,
Verónica,
Chandra.
¿querías agregar algún
Veronica, would you
comentario
like to add any
sobre
comments
estas preguntas y esto?
about these questions? Yes, I think that, well, first of all, just to show you that we are reading the questions, there are many, many questions about the use of contraceptive methods in practice. I think that is essential, and maybe it goes beyond what we can answer now at this webinar. I do recommend the manuals of the WHO. There we included the links. You can download them free of charge. The PAHO and WHO documents, there are in several languages. Asha summarized very well how to manage the side effects. There are many myths and taboos working with contraception in general, and specifically with adolescent contraception. There are many questions in the chat with emergency contraception. There are no problems using it when it's necessary to use them. And if you have to use them 10 times a month, then you will. Now, then you have to see why the girl is using it 10 times. But it's better to use it rather than not using anything. And it's important to say that because this is a myth that professionals continually repeat quite often. Now we'll give you the floor for that, Asha. And now I wanted to say that under sexual and reproductive health, I think that all this is very important from the academic and scientific point of view, but if it's not based on strong public policy related to access to contraception, improvements are changes in the legal frameworks, things will be much more difficult. From the Pan American Health Organization, from CLAP, we work with different legal contexts related both with pregnancy, interruption of pregnancy, abortion, and access to contraception, and places where emergency contraception is free of charge and a free access. In other places, it's more restrictive, places where abortion is absolutely banned. But however, there are always things you can do. There are always things you can work out. And that is also important. And it's important to consider the initiative you have, looking for a twist, seeing how to work it out. And you should try to find a place with the least resistance. In many places, you may enter through health access or post pregnancy. In other places, it might be easier to reach through sexual education or through post-pregnancy contraception. Well, and in Latin America and the Caribbean, we suggest you to contact the PAHO official regional offices. And we from CLAP will be absolutely happy to help you out in your processes, and with LARC and contraception in general. I think that this is a good opportunity to be able to get in touch. And I think that the easiest thing is that Melina, who's in charge of communications, answered you in the chat. So please contact the PAHO local offices. Maybe Asha could answer some of the questions directly related to her presentation. Yes, thank you, Veronica. Asha is raising her hand. Yes, I think that she does have something to say.
Yes, thank you very much. On the topic of emergency contraception, I just wanted to make a couple of points in addition to what Veronica has so eloquently said just now. So one of that is that it is great if a young person is seeking emergency contraception, because of course it shows that they are informed about it. And one of the best methods of emergency contraception is a copper IUD. And what we are doing here in UK, but really it should resonate around the world, is to make sure that whenever we offer emergency contraception, whether over the counter or through a pharmacist or through a healthcare professional, we should make sure that we discuss the copper coil and, if appropriate, offer it to the young person, because it is, as we said, age alone is not a bar for any method of contraception, and the copper coil will not only provide good emergency contraception, but will also provide ongoing contraception to the young person. So just a plea to not forget the copper coil as a method of emergency contraception. But I'm happy to take other questions. Thank you.
Muchas gracias, Asha. Yo quería retomar también.
Thank you, Asha. I also wanted to address the importance of our role as healthcare professionals, because sometimes it still happens that we think that it's people, mostly women, but not just women, and teenagers or girls and boys or non-binary individuals. Very often we think that it has to do with their culture, with their ideas, with their prejudices, and we don't realize how important our role is, providing information, making sure that they understood the information provided, and making sure that they are receiving what they need, and paying attention if they suffer violence, as Veronica said. It is very important for us to check our position and the way we work, especially with adolescents. Chandra, I give you the floor, and after this, I'll give the floor to Silvia and Marise, who will wrap up. Chandra, please. Thank you.
Thank you. Thank you for making that comment about the role of health workers. And absolutely, health workers have a very important role as service providers, but also as change agents. a capable, committed, empathetic health worker is crucial. Although, of course, parents are, teachers are, everyone else is. In many parts of the world, what we do is we spend an enormous amount of money in training health workers. 80% of the budget in many countries is used to train health workers. One of the things I said in the meeting in Kathmandu is one-off training of health workers. One-off means you just bring health workers for 3 days, you train them and you say trained, and we say trained health worker is equal to a competent and capable health worker. That is nonsense. You know, we have enough evidence that training on its own is absolutely useless. The approach that we are using in many parts of the world is we bring trained health workers. We do good quality training, yes. But increasingly what we do is we bring the trained health workers together for collaborative learning so that they learn and train and support each other. It's, you know, this cannot be trained by an outside expert. I'm going to share with you a paper that we have published based on our work in the Democratic Republic of Congo, where what we have done over the last 2 years is bring these people to talk and support each other. And what you said just now is, you know, we health workers have to feel comfortable. We have to not play the parental role. We should not be judgmental. It's very easy to say all these things in a workshop context. It's much more difficult to do this in a clinic. I worked for 10 years in Zambia. I remember a young person coming to me and saying, "Doc, I don't want a lecture. Can you give me condoms or not?" And I was so angry with him, but I just stomached my anger, bit my tongue, and gave him the condoms. But, you know, it's not easy to do that. It's not easy for everyone to do that. So I think if we want health workers to do certain things, if we want teachers to do certain things, we have to change the way we prepare and support them. Thank you. Over to you.
Gracias, Chandra. Silvia,
Thank you,
Marisa.
Chandra.
Por favor.
Silvia, Marisa, please.
Yo quiero agradecerles
I
a
want
cada
to
uno
thank
de los
each and every one of the speakers, each and every one of the people who have attended, and Teresa for leading this, and everybody's participation. We had over 600 people in this webinar. We had people from all over the world listening. Chandra, I pick up what you just said. In my country, we are experiencing a problem. The pandemic reduced the attendance of adolescents 50% with the ensuing risk. And we must continue because the administrations change and we continue struggling. I think that this webinar, with all the participants we had, will allow us to be clear in this regard. So thank you all. Marisa, the floor is yours. Well, there's not much to add. I want to thank you and pick up what Veronica and others said, and that is that ideally we want people to have a free enjoyment of sexuality without a risk for pregnancy of contagion of infection. And in relation to pregnancy, the idea is to experience it pleasurably. And what Chandra just said is true. We can't really teach these matters in courses alone, but work in workshops and with people willing or interested truly in this. We should be non-judgmental. We must listen to what people say and not put forward what we think before anything. Just listen before to know what they want from us and not the other way around. So I'm very happy to have had this together, to join efforts with all the different organizations, PAHO, FIGO, WHO, Chandra. Well, the truth is that it's much better to work together and compared to separately. So thank you all. We still have nearly 500 people connected and via YouTube also. So thank you all. Have a nice weekend. Hope to continue doing these things together. Thank you all.
Muchas gracias.
Bye.
Namaste.
Namaste.
Thank you.
Gracias a todas.
Gracias.
Thank you,
Gracias,
everybody.
Melina. por
Thank
el
you,
apoyo,
Melina,
Roberto,
for all the
Manuel.
support, Roberto, Manuel.
It was great.
Yes.
Thanks a lot.
Muy bueno. Gracias a todas.
Lovely.
Gracias,
Thank you
Silvia.
all. Thank you, Sylvia.